Hi, welcome to Getting Started in Telemedicine webinar series. My name is Anne. You can't see me, but just a few quick housekeeping items. So slides can be downloaded in the handout section if you're having trouble with seeing the screen. Unfortunately, I was only able to get one set of slides up, so these are for the legal side on the second presentation. Please put in any questions that you have for our speakers in the questions box. We'll get them at the end. We'll have time to answer them during the Q&A. And this session will be recorded, and we'll be sending access to this a few days after. It will include both sets of slides. And we have more webinars in the series. You can visit vsee.com/webinars for other webinars in this series. So with that, I'm going to go ahead and hand the time over to Dr. Goldman. You can't see him either, but he has a few words to say to us.
Okay, great. Thank you, Anne. I'd like to welcome everybody to today's webinar from multiple Bay Area medical associations and being sponsored by the Alameda Contra Costa Medical Association in partnership with VSee and the Global Health Impact Network. My name's Dr. Gary Goldman. I'm a council member for the ACCMA. I've been a practicing anesthesiologist at Alta Bates Summit Medical Center, a Sutter Health affiliate in the East Bay since 1989. I'm also a serial entrepreneur in the digital health space in continuing education, international nurse staffing, and cloud-based healthcare provider data management and credentialing. I'm currently, and have been for the last 8 years as well, a Sutter Health physician informatics lead for the Epic electronic healthcare record development, implementation, and optimization. I'm currently the founder and CEO of Global Health Impact Network, a clinician-driven collaborative network of clinical and digital health communities focused in the ecosystem of digital health innovation. We all feel it's imperative that clinicians play an active role in what we believe is the precipice of this digital healthcare revolution, being more enhanced even by the current pandemic. The ACCMA is a professional association of physicians who are committed to addressing health issues of concern to patients and doctors in the East Bay, and we provide a forum for physicians to come together to improve public health, the quality of practice of medicine, and patient access to care. This event is just one example of among hundreds of activities that the ACCMA engages in every year to help physicians. These activities include political and public advocacy, things like holding local meetings with elected officials on healthcare legislation, regulatory compliance, things like ensuring network adequacy for covered California plans and helping members comply with Medicare reporting programs, practice management assistance, things like presenting ongoing seminars and webinars like this one on practice management topics and helping members with reimbursement challenges. This webinar is the 5th in the series of 6, Getting Started in Telemedicine. Telehealth services are expanding rapidly during this COVID-19 crisis. The ACCMA is providing a quick guide to help physicians swiftly ramp up their telemedicine capabilities, from technology to practice implementation to coding. I'd like to take this moment to just thank VSee and Global Health Impact Network for hosting this webinar series for us. They have been a great partner with the ACCMA. I'd like to now introduce our moderator for today's program, Dr. Yuli Chetapalli. Dr. Chetapalli is a physician, researcher, author, and innovator. He is currently the president of Innovator MD, a healthcare innovation company. As a physician scientist, he's interested in technology-enabled care. He's received in the past the Pioneer Award for Innovation from Kaiser Permanente and Morris F. Collin Research Award from the Permanente Medical Group. His other roles include President-elect for the San Mateo County Medical Association. He's the chairman of the Society of Physician Entrepreneurs San Francisco Bay Area chapter. He's an advisor, mentor, and investor at various healthcare startups. He's also the author of Punish the Machine, the Promise of Artificial Intelligence in Healthcare. Take it away, Yuli.
Thank you, Gary, and thank you to our medical associations that are sponsoring this and VSee. Welcome, listeners. You have tuned into our seminar series and today's topic is legal considerations for telemedicine. And we have two presenters today, so it's my pleasure to invite David Ginsberg and Alan Briskin to our seminar. I think David will go first, so let me introduce David Ginsberg to you. David is the co-founder and president of Priva Plan Associates, Inc. He has 30 years of experience in the healthcare industry with expertise in HIPAA, medical practice management, and regulatory compliance. He is the official HIPAA advisor to ACCMA and the California Medical Association. David, welcome.
Thank you, Dr. Chettapalli, and I've just got a little technical issue here that I'm trying to resolve with my screen here that just happened. So hopefully we can figure it out. All right. There we go. Thank you, everybody, for joining. And some of you may have heard me speak last month on an ACCMA webinar that we did where we discussed some of these points just as the COVID crisis was emergency was beginning to take hold. But today, my presentation is going to focus even deeper on some of the best practices related to the fact of workforce having to reposition to their homes that creates new HIPAA privacy and security challenges, and how telemedicine indeed is adding to these challenges. In fact, I've just looked at a graph earlier today that's a data graph that shows by county in the country how much telemedicine has increased in the last 3 weeks. And it's up around 2,000% from where it was before, reflecting the fact that many, many, many physicians have had to reposition to work either from their office or more likely from home to do telemedicine. Specifically today, we're going to talk about the enforcement discretion that was announced by the Office for Civil Rights to give a broad and yet good enough understanding to know what is discrete under the Office for Civil Rights enforcement action and what are you still going to be liable for over the next couple of months or forever long as the emergency is in effect. And then some best practices for telemedicine, working from home or from the home workplace. So why was there enforcement discretion? I think the term
Hi, did is the sound stopped for anyone else?
Yeah,
For
I can't hear him, man.
Okay. Hey, David? David, can you hear us? Uh-oh, the sound just went out. Let me see if we can, oh, I think he stopped. Oh no, okay. Look at the last slide.
variety of hurricanes, the one that hit Puerto Rico,
Hey,
the one
David?
that, yes.
David, we actually stopped hearing you for a brief period of time, starting at your last slide. So you might want to go back and it was just a really weird.
Oh, it's very weird.
Yeah. I think you lost. Yeah. So I think the audio just disconnected for like
just
a minute or something like that.
Well, and in fact, I think folks are finding that all these platforms that we're using, these telemedicine, televideo platforms, are being so overwhelmed, they're having their little glitches. So in case you didn't hear, the purpose of this particular slide was to show why the enforcement discretion was put in place to support and allow the providing of care, in this particular case, telemedicine kinds of care, without concerns about certain parts of the HIPAA compliance regulation or rule. But it's not a blanket waiver, as I just earlier noted, and similar waivers have been provided during recent hurricanes like hurricane that affected Houston a couple of years back or the Puerto Rico. So let's examine what this discretion is, the enforcement discretion. And we felt that the best way would be to give you the actual text because it's as clear here as it can possibly be. And what they're saying basically is a covered healthcare provider. So if you don't remember your HIPAA 101, if you're covered by HIPAA, you're known as a covered entity. So a covered healthcare provider, and that would include virtually every one of today's attendees. Only a few might not be covered by HIPAA, although you might be covered by California law, that wants to use audio or video communication technology to provide telehealth to patients during this nationwide public health emergency, can use any non-public facing remote communication product. And that the Office for Civil Rights, so they're an agency under the Department of Health and Human Services, they are the ones that do HIPAA enforcement. They're exercising their discretion that they have during a declared national emergency to not impose penalties for non-compliance, not with all the HIPAA rules, but with particular rules that are in connection with what they consider good faith provision of telehealth using non-public facing audio or video. Now you notice that that terminology, non-public facing, is used twice in the statement. We'll come around to this about why this is important to know what this means. But they do go on to say it doesn't matter whether you're using telehealth for a patient that has suspected or presumed COVID-19 diagnosis or any other kind of patient care that you're doing. Any patient care done by telemedicine during the time of the declared nationwide public health emergency will be subject to this enforcement discretion under HIPAA. Furthermore, under the notice, a covered healthcare provider can use popular applications that allow for video chatting. And it's important because they give us some examples. For example, they give FaceTime. So if you're using an iPhone or an iPad, or you have other, quote, Apple technology, you can use FaceTime. Facebook Messenger video chat. Now, this isn't Facebook groups. This is the Facebook Messenger video chat, Google Hangouts video, Skype, even WhatsApp. WhatsApp is an extremely popular application, especially among the Asian community and especially among young people. That is a secure application that can be used for video chat. To provide telehealth without risk that the Office for Civil Rights might seek to impose a penalty for non-compliance with HIPAA rules. But they go on to say in this very same notice that providers are encouraged to notify patients that these third-party applications potentially introduce privacy risks and that you should enable all available encryption and privacy modes when using such applications. So I put the emphasis there because there are settings that are available on all of these different technologies that can ensure that encryption has been set up during the technology to ensure that the video chat is secured and also to even block anybody from joining or coming into that particular session. Further, they clarify about what are public-facing versus non-public-facing applications. So where FaceTime and Google Hangouts and Skype are considered non-public-facing applications, Facebook Live, Twitch, TikTok, or other kinds of video communication are public-facing. That means they can be seen and broadcast to any of the friends that your patient would have on their Facebook page or Twitch page or TikTok page, and thus that video conversation is public-facing and not private. Those are absolutely not allowed. Only the non-public-facing popular applications are allowed. They further go on, and this is another important statement to say, providers that want or seek rather additional privacy protections for telehealth while using video communication should provide such through technology vendors that are HIPAA compliant and will enter into a HIPAA business associate agreement in connection with the provision of their video communication product. They go further to even define certain technologies that are HIPAA compliant. For example, they mention Zoom, and in recent notices they mention WebEx, GoToMeeting, and a variety of other private or telemedicine telehealth platforms, Doxy.me, which is a free telehealth platform, all of which will sign a business associate agreement and hold themselves out to be HIPAA compliant. So while the Office for Civil Rights will not impose penalties against the covered entity during the COVID-19 emergency, it is important to know that you still want to be compliant if you can, especially after the emergency is declared. That's why we say we believe this is a slippery slope. If you don't obtain a business associate agreement and you choose to use one of these platforms, so not FaceTime, not WhatsApp or Skype, where you wouldn't get a BA normally, or Google Hangouts, but you choose to use Zoom or WebEx or some other platform without a BA and getting that, they won't enforce the lack of that business associate agreement. But once the COVID-19 emergency declaration is over, then you are actually going to be non-compliant if you haven't obtained a business associate agreement. Now, the good news is virtually all the commercial technologies, including the free ones like Doxy.me, will provide a business associate agreement. The business associate agreement will not be up to the level that the ACCMA, the California Medical Association, and the various other medical associations would like, meaning it won't incorporate California law, it won't have typically the reduced number of days for notification that we like to see under California requirements, but nevertheless, it will satisfy HIPAA of having a business associate agreement, and at the very least, you will have the assurance that the vendor has gone through sufficient internal review to have a compliant platform, because typically they have quite a bit of information to describe how compliant they are with securing the web sessions and their data. So that's what the enforcement does. So notice the enforcement doesn't come along and say that you're out of, don't have to worry about HIPAA and somebody overhearing the conversation. It doesn't say that you're no longer subject if you email a patient incorrectly or you email the wrong person, a patient's protected health information, or that if you use text messaging for PHI, or if your computer gets hacked and the information gets pulled out of your system, or your electronic health record gets hacked, none of that has been waived. The only waiver is related to the use of telemedicine platforms that may not be HIPAA compliant during this declared particular emergency for that time frame. So as more of your workforce has been repositioned to work from home, there are a few best practices that we want to go through. Obviously, many of you on today's webinar are physicians, and many of you may also be staff members of the practices. So you've moved virtually everybody, in some cases, off-site. In other cases, you've got a very skeleton crew at your facility or office if you're still seeing patients. If you have more of your workforce working from home, we recommend that it's critical to have something called an acceptable home use policy agreement. That's just a good standard HIPAA policy to have. In fact, the California Medical Association Private Plan HIPAA Toolkit has had one of those in place since 2005 as a recommended policy that would define security, privacy controls that are relevant for any kind of home activity or use of electronic protected health information from your practice. What are some of those areas that you want to ensure? Well, we all would be using a home Wi-Fi unless you have a business office at your home and you've got a business Wi-Fi. Is that Wi-Fi something that's being used by other family members? Has it been set up to have a password and WPA2 or greater encryption? That is absolutely a necessity to ensure that that particular Wi-Fi transmission cannot be hacked into by any rogue player or actor. And especially if you're in an area where your signals can be intercepted, and they can within a few hundred yards of where you're located. Just take a look at the available Wi-Fi signals whenever you look at Wi-Fi near you, and you'll know that all of those signals represent somebody that could come in and potentially access your data streams, your transmission screen or streams. So you want to secure your Wi-Fi by an encryption key, which usually requires a long, lengthy password that gets typed in. It's password usually of numbers and symbols and letters that defines what that encryption key is to unlock the encryption. Just as important as technical security is that you would work from as private an area at home as possible and not allow family members to overhear or shoulder surf your screen or workstation or even your smartphone displays. So that's part of the privacy component. Equally important, just like at your offices, because if you're home, if there's anyone other than you in the home, it's critical that you would log off when you get up and leave your computer, workstation, or smartphone, unless they log off within a very short period of time when they're unattended, and not just a screensaver, but an actual log off. Not using sticky notes to remind yourself of what the password is, because that way somebody else in your home will know how to log in, and not using personal computers for these activities of telemedicine or even accessing your networks at the office or your electronic health records, unless you've been given permission by the IT folks at your company or somebody else that your personal computer is secured enough that it can actually do the login and the other kinds of activities where protected health information is being accessed. We also think that data should not be saved on local media, nor should data be printed on a local printer unless you can secure that immediately, again, if you live with anybody else who might be able to take that information and see that. None of this would be protected under the enforcement waiver. So for example, if you saved patient information on an unencrypted USB thumb drive, and then you took that thumb drive with you and left in the car, and the car was broken into, and the thumb drive stolen, you would be subject to HIPAA enforcement. In fact, that is an exact situation that happened several years ago in a dermatology practice, and the penalty, not the fine was several $100,000, but the penalty they negotiated and paid was for $50,000. That's still going to be a penalty that you'd be faced even under this enforcement waiver. As we said earlier, the same restrictions on texting or emailing for PHI apply for home use as they might for medical practice. So it's tempting when you're doing telemedicine or using your smartphone to say to the patient or have them say to you, I'll text you the information, but that is not a secure channel. Not unless you are using a secure text. Now, some of you, your EHR systems let you securely text. Some of you might actually have Tiger Text within your office, and they now have a new patient-facing secure encrypted texting methodology. I'm not promoting anybody, I'm just suggesting that that's one application. You have to use these secure applications. But here's another point that a lot of folks forgot about. Many of us now have, we call them virtual assistants, right? Such as the Amazon Echo Show, Google Nest, Siri or Android, that listen and will wake up based upon their name or commands being used. And they'll potentially transcribe and take that information. These devices should either be used far enough away from your conversation, so you should be in a private setting that they can't overhear, or they should be disabled so that they would not be hearing protected health information during the session, or even if you're describing or talking with a coworker by use of one of these devices or telemedicine or teletechnology, telehealth technology, telemedicine platforms. These devices, if they listen to this information, are potentially creating a HIPAA violation environment. In fact, some of us may have already had the experience where you're just talking and all of a sudden your Siri iPhone wakes up and begins to transcribe, or your Alexa device wakes up and begins to transcribe. In fact, I just looked at my Alexa device to make sure it didn't wake up as I said that, and it's far enough away and it hasn't. When you're using teleconferencing like Zoom, GoToMeeting, BlueJeans, WebEx, you as the moderator conducting the telemedicine session with your patient have a variety of privacy and security controls that you should enable. For one, be sure that the end-to-end encryption has been turned on. The second is be sure that a password is required and you communicated that password to your patient. If there's a password, that prevents anybody else from intercepting and trying to log in. What you've heard about called Zoom bombing. So the Zoom bombing where public Zoom sessions have been given with a public link to everybody, and folks who weren't authorized to come in have come in, taking controls and put up pornography, taken over screens and things like that. In fact, with many of these systems, not only in addition to requiring a password, once your patient has logged in, you can lock the session and ensure that nobody else can come in at that point, which is like closing the exam room door in your medical practice. So close the exam room door by locking a session. In fact, depending on the technology, you could even create a waiting room and invite people in. You can restrict or stop chats. You can disable the patient from being able to record, and you do want to do that so that the patients aren't recording that session unless you want them to. And you can even temporarily pause the screen when you create a new or open a new window so that they don't see this other window or screen that you have. And from a privacy perspective, for the first encounter, it is important to document that you've asked the patient for their consent using the telehealth, telemedicine technology. Document that in your clinical record or appropriate environment within your record, the time and date. And of course, it's good practice to talk to patients, especially to be sure that they themselves recognize that they are potentially going to be overheard by other family members, just like you would in the exam room. You would say, if the patient brings somebody with them, is it okay for us to talk with your husband or your daughter or son or your caregiver and get the patient's consent, as long as they are competent and capable to give that. So all those same requirements should apply to telemedicine and be well documented as in your record as well. So that's the end of our program. I want to give Alan plenty of time to go through his presentation. Again, please use the chat feature or the question feature, and we will respond to questions when Ann opens the lines up later.
Thank you, David. Our next guest is Alan Briskin. Let me introduce him. Alan Briskin is a healthcare law attorney at Pillsbury, Winthrop, Shaw, Pittman. He advises healthcare providers and payers in the business that serve them in a variety of legal, regulatory, and business concerns, with particular emphasis upon privacy and data security, healthcare payments, and licensure issues. Alan, take it away.
Oh, thank you, and good afternoon, everyone. So this slide just gives a quick overview of what I'm going to be talking about. There have been a great many changes in rules, both at the federal and state level, that affect telehealth. And I think the most interesting and significant of them are temporary expansions of coverage, increased opportunities for payment, the relaxation of rules, certain rules around anti-fraud, waste, and abuse, and cost sharing. There's been we're seeing a temporary relaxation of rules regarding practice across state lines and collection of patient consents. Spend a little bit of time talking about additional opportunities for federal funding. There are money sources available that haven't been historically, and they should we should be paying attention to them. I'm going to skip over the HIPAA parts, which David has just covered, but I wrote these slides before I knew what David had in mind. And this is another example of how we wrote this before we had coordinated. There are, I thought it too would be helpful to put this conversation in context around what HHS had said was motivating its change in policy. And so I think the key concepts to keep in mind here, and it's what explains the motivations behind some of these changes, are the perceived urgency to expand the use of technology to help people who need routine care and to keep vulnerable people and people who have COVID-19 with mild symptoms in their homes while maintaining access to the care that they need. Underlining the public policy that it's imperative during the public health emergency that patients avoid travel when possible in situations where they could risk their own or others' exposure to further illness. Some of what we're seeing are changes to the rules, others are changes to enforcement choices, and that can have implications for what they mean and how. I mean, David certainly explained well about how the difference between a change of a rule and a change of enforcement practice is relevant towards looking at how privacy and security is handled appropriately. All of these changes are described as temporary, but I think it's worth asking the question, does that make sense for all? And should we be going through this process trying to identify opportunities to make certain changes lasting? So the first set of changes here are that Medicare will pay on an expanded basis for services provided by telehealth. Medicare has up until now been covering e-visits and brief check-ins, but telehealth has been limited to situations, generally speaking, where individuals were located in rural areas and were accessing care in specific healthcare facilities, and also in which the individual already had a relationship with the provider who was performing those services. And now, under the changed rule, telehealth visits are going to be considered for purposes of payments to be the same as under Medicare, to be the same as in-person visits and be paid at the same in-person rates. It's worth noting here that the expansion of coverage is not related to COVID testing, diagnosis, or treatment, but that the expanded coverage applies in addition to the existing coverage, that it applies to any medically appropriate service, and that it applies in addition to the existing coverage for virtual check-ins and e-visits. So, to enjoy coverage under the expanded eligibility, services can be provided by physicians, by NPs, by PAs, nurse midwives, certified nurse anesthetists, clinical psychologists, clinical social workers, registered dietitians, and nutrition professionals. As I said before, one of the existing rules around telehealth is that the patient has to have a prior established relationship with the practitioner. That requirement remains in effect, but HHS has said that it won't conduct audits to ensure that the relationship existed. Worth noting that that puts the provider in a position of, if the provider has mechanisms in place to document that and to demonstrate compliance, it should keep on doing so and note the situations where it couldn't. Another point to note here is that for Medicare purposes, Medicare coinsurance and deductibles still apply, and routine waivers of cost-sharing amounts remain generally prohibited under the fraud, waste, and abuse rules. But the OIG has said that it will exercise enforcement discretion for providers who reduce or waive cost-sharing for telehealth visits only. But it's key to note that they stated that flexibility does not extend to virtual check-ins and e-visits. It doesn't extend to anything else either. So the prohibition on routine waivers of co-payments and deductibles remains in effect. We have a narrow temporary window during which waiving or reducing co-payments in connection with telehealth is not going to lead to enforcement action. These changes took effect retroactively to March 6th, 2020, and they're going to remain in effect through the end of the public health emergency. Since we're talking about virtual check-ins and e-visits on one hand and expanded telehealth on the other, it's worth noting what billing codes we're talking about. And so I've listed the ones here that HHS has identified as being the ones that are most likely to be involved, but there's a link here to the complete list of the codes that'll apply to billing for telehealth services. So up until now, I've been talking about fee-for-service Medicare. CMS has also stated that all the Medicare Advantage plans, private plans that cover people under Part C, have to provide the same coverage with respect to telehealth. It's also worth noting before we leave CMS to note that they announced temporary suspension of a number of supervision, licensure, and certification requirements that allow physicians to directly care for patients in specified settings through telehealth. The most noteworthy one is CMS has said that they're not going to be enforcing the certification requirement that physicians be licensed or certified in the state where the patient is located. It's worth underlining that that's CMS's relaxation around payment for services. State laws regarding unlicensed practice remain in effect, and it's worth noting, I checked this morning, as of today, California Medical Board has not opened up California's borders to practice within California by physicians who are licensed outside California. For that to happen lawfully in accordance with the California rules, the out-of-state physician, the one not licensed in California, still needs to have involved a consulting California licensed physician. It's worth noting also that this flexibility around certification is limited to specific locations in which services are provided. Changing it as we walk our way through the various payment programs, CMS acted to clarify that state Medicaid programs can expand their services to cover telehealth and other services as well, and simplified the process by saying that the states don't have to modify their state Medicaid plans to do so. And the California Department of Healthcare Services followed up by announcing on March 24th, the general rule is that services that are provided by telehealth to Medi-Cal beneficiaries in California, if they're properly coded, will be payable at the same rates as in person if the treating healthcare practitioner believes that the Medi-Cal benefits or services being provided are clinically appropriate based upon evidence-based medicine or best practices to be delivered by telehealth, subject to oral or written consent by the beneficiary. Interesting point. I'm going to talk about that in just a minute, but as of March 24th, DHC has said that patients still had to consent to telehealth. What's not okay, and some of this, of course, is obvious. It would seem benefits or services that are provided in an operating room or while the patient's under anesthesia. But the key two parts are numbers 2 and 4 on this list that DHCS gave us, which is that benefits or services that require direct visualization or instrumentation of bodily structures, or that otherwise, in the physician's judgment, require the inpatient presence of the patient, are not suitable to be treated by telehealth. It's kind of an obvious point that you'd think of in your professional judgment about determining what's appropriate or not, but I'm making the point to illustrate that it's built into the payment rules as well. And here again, as David did, I think sometimes it is worth looking at the exact language that they've said, is that this rule extends that I've been describing. I've been talking about fee-for-service Medi-Cal up until now, so we're now talking about managed Medi-Cal plans, but the same rules apply, just expressed in different words, and that the Medicare managed care plans have to pay providers at the same rate, whether a service is provided in person or through telehealth, if the service is the same, regardless of the modality of delivery, and that's going to be determined by the provider's description of the service on the claim. In other words, if it's properly coded. That's enough on that point. To move then, as we move then into commercial payment, as you know, California regulates health plans separately from health insurance companies, and so the Department of Managed Healthcare regulates the health plans, the Knox-Keene plans, and on April 7th, the DMAC expanded its prior order to say that all Knox-Keene plans have to pay providers at the same rate, whether or not service is provided in person or through telehealth, if the service is the same, as determined again by the coding. It places a limit on the health plan's ability to go back later and recode, even though your health plan contract typically provides that the plan can recode. This would limit the plan's ability to do that. Adding here that the services provided by telehealth may not have a higher cost sharing requirement. Payment's supposed to be the same if the modality is appropriate. It's worth underlining here too that we're still talking about all services that are medically appropriate, not just those that are related to testing, diagnosis, or treatment of COVID-19. The DMHC acted first in mid-March. By the end of the month, the California DOI had caught up and actually ordered even more than the DMHC did by incorporating the same general principle about health insurance having to pay for services provided via telehealth if it was medically appropriate to do so, but imposing an additional burden on PPOs and other plans that are regulated by the Department of Insurance to require the plan itself take additional steps to facilitate increased availability of services by telehealth. And again, we see that the wording is different here, but the payment rates should mirror the payment rates for an equivalent office visit. So then the next category of payer are actually what covers the majority of people who have commercial healthcare covered in a state like California, which are those who are covered by self-funded plans that are then administered through third-party administrators or TPAs. And of course, all the big health plans have their own TPAR. And it's worth noting that at this level for employer self-funded plans, there is no regulatory framework that's equivalent. And therefore a narrow approach. You don't have a regulator who can do what the DMHC, what CMS did, or the DMHC or the DOI. So the approach is narrower. Under the first of the two COVID response acts passed by Congress, the Families First Act, requires that all employer-sponsored health plans, which are commonly referred to as ERISA plans, have to cover all tests for all costs for diagnostic testing services related to COVID-19, including but not limited to telehealth. So all costs means no cost sharing. Co-insurance deductibles have to be waived for these services, but all costs does not include treatment of COVID-related conditions, and it doesn't include treatment of non-COVID related conditions. Therefore, the diagnosis or treatment of those conditions. Therefore, we've got a significant patient base in California who are not covered by these expanded rules regarding payment. The California Workers' Comp, the Division of Workers' Compensation caught up and announced that they have, say, broader coverage for telehealth services, generally following Medicare's approach. And then Governor Newsom acted with the executive order, which did a few interesting things. Did a number of things with respect to telehealth. I've listed three of them here, and then I've listed three here I want to talk about. I'm sorry. Even though the Department of Healthcare has, or rather, excuse me, Department of Healthcare Services had said that for telehealth, one still needed to document the patient's verbal or written consent. Governor's office overrode that, and so there's temporary relaxation of that requirement. Even though I still think if it's possible to do it, it's definitely the right way to do it. And then also, and this I think is relevant to what David was talking about all the different HIPAA violations that you can still commit, even with the relaxed enforcement that HHS, that OCR has announced. One point about HIPAA is that HIPAA doesn't have a private right of action. I, as an individual, may have rights under HIPAA, but if my healthcare provider violates my rights, I can't sue my provider on that. The only party who can go after my provider under HIPAA are it's the federal government and then state and local governments with some narrow rules around that. For healthcare providers being exposed to other than government enforcement action, but for lawsuits arising out of privacy violations or security violations, including breaches of their private information. The April 3rd executive order sought to limit those in order to be held liable on those bases. It's generally a matter of state law, and the governor's office tried through a number of statements in the executive order to limit the extent to which if you do some of the things that the law, that the relaxed enforcement permit, that traveling along with that,
Hey,
you're not going to be.
Hey, Alan, sorry.
Yeah.
I'm getting a couple of complaints that your audio is going out a little bit. It's sounding okay for me, but I don't know if you can maybe talk more into your mic or something, or
Okay, I
we're
will
kind
try.
of getting down to our time too, so maybe we
Okay,
want to start our Q&A session. Do you want to go ahead and wrap up? And
okay, will do. Just wanted to note a few things. They're in the slides. The Stimulus Act, stimulus bills do take into account or do make available certain opportunities for funding that should be of interest to providers, certainly those who are associated with larger organizations that have the resources to submit applications should be looking at this as ways to help pay some of the costs as well. And so I can finish up with that.
Great. Thank you very much, Alan, for that detailed information. Now it's time for questions. So let's see, the first question comes from Israel. And Israel is asking, when I provide a video visit for cash and the patient goes and submits a claim to their insurance, what should I do? Should I disregard that insurance payment? And what if it is Medicare? Can they do a visit outside of their insurance? Alan, can you answer that?
If I'm understanding correctly, and now I'm afraid the audio problems are coming my way, the question is when patients seek to just pay cash for telehealth services, what's the appropriate act by the provider? And regrettably, it depends on how the patient is covered. If it's a Medicare patient, you're a provider who's participating in Medicare, you've got an obligation not to bill more than the Medicare amount. So you can't collect more than whatever the patient's financial responsibility be under Medicare. Similarly, if you are a contracting provider to an Knox-Keene plan, your provider contract has to prohibit you from collecting anything more from the patient than their copayment or their deductible. So if the patient has coverage for this service and you charge the full amount of your bill, don't run it through the health plan, you're violating your health plan contract. It's not required that it be that way when you're a network provider for a plan covered under the Department of Insurance, but generally your contract will require the same thing even if the law doesn't demand that it be there. And then the same applies also when you're treating a patient who is covered by a self-funded plan. There can be more flexibility about that, but typically speaking, when you're seeing a patient as part of your participation, say the Aetna, the Blue Cross, the Cigna network, your provider contract with them limits your ability to bill for that. So really the only people who you can collect the full amount from are those where they're either not covered by Medicare or you're a non-contracting provider for their payer.
Great. Thank you very much. The next question is for David. Now, when it comes to video visits, is there anything off limits? For example, a genital exam or a genital exam on a minor. Is there anything off limits?
There's nothing in the enforcement discretion that would speak to that, because that really falls out of HIPAA, and that's more a standard of practice, as Alan will tell you, in professional duty. Minor visits are an issue. However, I'll just share this from, there are some participants from Planned Parenthood and maybe some of the federally qualified health centers in the Bay Area that are doing quite a bit of minor work with regards to where a minor has the right to reproductive health at a certain age. And the concerns there are more around the privacy of that minor's ability to have that visit like they would if they were in the office, rather than at home where they may be overheard. You have to be somewhat cautious about preserving that privacy. But the HIPAA reg and the enforcement issue here from discretion would not have any off limits, you would do, I think, Alan, correct me if I'm wrong, you do what you need to in your professional judgment for the purpose of that visit with the patient, even though it's by telehealth. So you certainly don't want to get into a medical malpractice situation where you're not being complete enough in your exam or your telehealth visit.
No, I agree 100%. There's no relaxation on any of the physician's professional responsibilities around conducting an appropriate examination before making any, ordering any test or procedure or prescribing or giving the patient any indications at all. And so there are practical limitations on telemedicine that remain.
Great. Thank you. This question is for Alan. Margarita asks, let's say there is a dentistry office, but you as a dentist is not working there usually, but during COVID, can I provide teledentistry for that office during this emergency? Alan?
It's an interesting question. Other than, the orders that have been, it's a very interesting question. CMS has not spoken to it, and I don't believe that Department of Healthcare Services has said, Medicare doesn't cover dental. That's the reason that CMS has been silent on it. I'm not recalling Department of Healthcare Services saying anything special about Medi-Cal dental. In addition, neither the Department of Managed Healthcare nor the Department of Insurance limited their advice regarding mandated coverage to hospital medical, what are called in the non-scheme related full service plans. The order that the department gave would be applicable to all healthcare service plans, which would include dental plans as well. So I would say if the service is still something that can be lawfully provided, if it's something that one would have done anyway, it should be available for payment. I'm going to also, just admit to you, this is not a subject about which I've seen people writing much on. It would be worth checking in with the health plan with the question first.
Okay. All right. Alan, can you elaborate on the FCC funding for telehealth, please?
Oh, okay, sure. The FCC program, and forgive me, I am going to go back to my slides as my notes on this part. Most significant part about this program is, sort of fair warning up front, this is a very small program. And CARES Act appropriated $200 million to a telehealth program by which the FCC would provide funding to pay for telecommunication services and broadband connectivity, information services and internet-connected devices and equipment that are necessary to provide telehealth services. Key limitations
Alan,
are—
can you share the slide? Can you share the slide?
Let me see if I can. Does it show up now?
Yeah.
Okay. I'm seeing a red. Okay, so now the bar is green, so I'm hoping you can see it now.
We can see it.
Okay, so the primary limitations on this are, first, it's $200 million, which is a drop in the bucket. It's just worth noting, the SBA program SBA loan program already ran out of money, which was in the hundreds of billions, and state and local programs are running out of money quickly. I haven't been able to tell if the $200 million has been exhausted, but if it hasn't, it will be. So it's sort of watch this space to see if this is something that expands further. Then the second limitation is that the eligibility pool doesn't go as far as the CARES Act funding. Individual physicians are not eligible for this, nor are larger medical groups or IPAs. The only real paths into this are teaching hospitals, government agencies, community health centers, and nonprofit hospitals, RHCs, and skilled nursing facilities. So I think I put it up here mostly to talk about, a place to look for future expansion as this goes further. Because one of the points that I want to make in this is that telehealth isn't just here. I think we shouldn't just be thinking about this in terms of how do we address our immediate emergency, but in terms of what is often described as the reopening of the country. Telehealth can be one of the pathways by which we return to normal. And so the issues around telehealth are going to remain interesting for weeks and months to come. I mean, this is not all going to be irrelevant once we pass whatever date ends up for the quote unquote the reopening.
Thank you. And this is our last question because it looks like we're running out of time. This is for David. What if some of our patients are not computer literate and they want to use their smartphone, but they're able to use their smartphone? Can we do telemedicine through that?
Absolutely. And that's why, in fact, of the notice of enforcement discretion, they were discussing some of the non-public applications, such as using the FaceTime application or Google Hangouts application. You can use Skype on your smartphone, or you can use WhatsApp. And in fact, depending on the community that you're in, you may find that even a lot of your seniors have some of these applications. FaceTime is basically built in to an iPhone, and it's pretty darn simple to use. So they can use those particular applications for telemedicine. It is interactive. It's a asynchronous process because you're talking, they're talking, you can see what's going on. So they're perfectly viable to be used.
Thank you, David. And thank you to Alan Briskin and David Ginsberg for this informative session. With that, we come to a close, but there's one thing, a reminder for you to join us on Friday, April 24th at the same time, 12:30 to 1:30 for our final webinar in this series. We'll have a panel of physicians who have gone through the process of taking their practices online. And so they'll share some tips and best practices for other practitioners who may want to do the same. And thank you very much and stay safe.
Thank you.